So on Friday, we will revisit neuropathy and talk a little bit more about how you treat neuropathic pain. I know this is something you discussed in detail in neuropsych, so take a look at those and review those concepts, and we will talk about what medications on Friday we use to treat peripheral neuropathy, as well as some treatment options for gastroparesis. Third and very important microvascular complication is nephropathy. So it's the largest contributor to end-stage renal disease as a result of diabetes. Increased risk of death, and largely from cardiovascular death, as a production in terms of kidney damage related to diabetes. This is defined, nephropathy is defined by urinary albumin excretion, which we will go into more detail on Friday, and talk about how we identify nephropathy and what our treatment options may be. Most of this is very similar to our blood pressure control, which we will also talk more about on Friday. So risk factors for the development of nephropathy include poor glycemic control over time, pre-existing hypertension, as well as hyperlipidemia, high intakes of protein, smoking, and genetics. And so you can see nephropathy, the difference between a healthy kidney and a kidney in patients with diabetes is we get this breakdown of the microvasculature within the nephron, which leads to leaking of the proteins out of the kidney and into the urine, and resulting in proteinuria. And that's what we're measuring with that urine albumin excretion, is that protein in the urine excretion of proteinuria. And we will talk about that in more detail on Friday. The prevention of diabetic complications. So we want to make lifestyle changes early, very much wellness and prevention and follow-up with primary care physicians, as well as routine medical care and follow-up with a potentially interdisciplinary team. Dr. Foley will talk a lot about these lifestyle and lifestyle modifications that can be made in order to prevent the progression of diabetes, and then prevent these diabetic complications that result of prolonged untreated hyperglycemia. This is specifically important for those that fall into the pre-diabetes category. These lifestyle changes early and good wellness care and routine medical care follow-up can help prevent that progression into the diabetes category, which in then turn will prevent the complications that come with the diagnosis. So managing risk factors and comorbid conditions also are an important factor. So managing the hypertension and the hyperlipidemia and obesity, along with managing the blood sugar, are all important factors in reducing the complications of the diabetes. So obviously glucose control is going to play a major factor there as well, and using appropriate pharmacological management, which we're going to spend a lot of time talking about with Dr. Fraser. Before we leave this topic, I wanted to touch on gestational diabetes, which also is very common among pregnant women. It affects about 7 to 10% of all pregnancies, and this is similar description to type 2 diabetes, except it is defined as a glucose intolerance that's first recognized during pregnancy. So patients that are euglycemic normal before pregnancy, diabetes is induced by the pregnancy. If left untreated, it can lead to an increased risk of morbidity and mortality for both mom and baby. Women with gestational diabetes are more likely to experience pregnancy-related hypertension and preterm cesarean delivery. And all of those increase the risk for type 2 diabetes in mom postpartum. So typically, if there's no complications, gestational diabetes will resolve after the pregnancy completes. These complications increase the risk that the mom will develop gestational diabetes after term. And the children of gestational diabetes are then at higher risk for obesity and diabetes later on in their lifetime. So some details on the pathophysiology related to the gestational diabetes is that estrogen and progesterone are early in pregnancy help decrease glucose levels, but as pregnancy progresses, the glucose levels continuously rise, leading to an increase in insulin production and potentially an increase in insulin resistance due to that beta cell constant production of insulin. So there may be some predisposition there to beta cell damage or activity prior to the gestational diabetes, but the added push of having that child in there and having the increase in glucose during the pregnancy prompts this progression to gestational diabetes during pregnancy. So in order to improve those blood glucose levels, more insulin administration is needed via that maybe simply your body producing more insulin, however that's resulting in a higher blood glucose level than is normal, or the level that we may need to administer medications which include insulin. The diagnosis of gestational diabetes usually occurs around 24 to 28 weeks of gestation. The earlier the diagnosis possible, the better. High-risk patients, so positive family history of gestational diabetes, if they're obese or they've had history of gestational diabetes with a previous pregnancy, they should be screened as early as possible. We use that oral glucose tolerance test for diagnosis of diabetes. Other risk factors for screening include patients that have PCOS or belong to a high-risk ethnic group, or they had a previous infant that was large for gestational age. They also might be people that you may screen a little bit earlier. So the screening as I mentioned, is oral glucose tolerance test. They can provide 75 grams of oral glucose to the patient and then test their blood sugar at different time points. So prior to administration of the glucose, their blood sugar is tested, then 1 hour, 2 hours, and 3 hours after, depending on their readings. So after administration of the 75-gram oral glucose tolerance test, they will check to see if their 1 hour glucose and it's greater than 180. If it's over 2 hours and it's greater than 155, they would be considered gestational diabetes. If they were screened with a 50-gram oral glucose tolerance test and their 1 hour glucose reading was greater than 140, they would then go on to receive the 100-gram oral glucose tolerance test and then go through the same stages of the fasting, 1 hour, 2 hour, and then a 3-hour test. And then they would just continue these cutoffs to be characteristic of gestational diabetes. You also learned in renal, which we will not cover here, diabetes insipidus. I just wanted to point out that that's unrelated. While there are similar symptoms, remember that diabetes insipidus is related to ADH and is not related to dysfunction in the pancreas or beta cell production and insulin sensitivity. So for our class on Friday, for tomorrow, I have some self-assessment questions that help you work through much of the pathophysiology that we talked about today, help you identify areas that maybe not have been clear today during the lecture. So as you're reviewing tonight and answering the self-assessment questions, please write down points that you think were unclear from lecture today and bring them to class tomorrow morning, and we will have time to go through and answer any questions that you might have regarding this material. For Friday, please review hypertension, lipids, and cardiovascular risk reduction from the cardiovascular block, review treatments for depression and neuropathic pain from the neuropsych block, and be ready for discussion regarding those treatments during Friday's class. After that, on Friday, we will also go into treatment of the complications that we introduced to you today, so retinopathy, neuropathy, and nephropathy.